all chapters on burns, so just make a note of that. That any of this that you need kind of further clarification or something that you'd like to simplify more. And there's sample questions in the back of it too, so that's good. ATI Med Surg, chapter 75. So, we're gonna talk about the different phases, so how we're gonna manage the burns. Okay, so the very first phase, very fitting name, emergent phase. It says that, this is a very important stage. It says it does technically, it begins when they get to the facility, but as far as the fluid resuscitation aspect of things, we need to know what time the injury occurred. Because when we get into this formula, we're gonna identify that they need to get all that fluid, a certain amount of fluid in within the first 24 hours. And that first 24 hours begins from the time of the burn. So it is very important for the care to be initiated. Like you see, the first thing there's airway maintenance. So we know we can't lose our ABCs in the burns. We know it affects the skin, but we have to be sure that they do have a secure airway. So our main goal in this phase is we're trying to eliminate any life-threatening issues that are resulting from the burn injury. And that's what we also have to account for. Is the respiratory system involved? Do we have a secure airway? And do they have a REC? Do they have other injuries that are also involved with this? But that airway is going to take the top priority. And then there is a fluid resuscitation table, and that's on, it's table 51.7 is an example of that. It's on page 1167, and I had marked out in the, did you find it in the old book too? Yeah. Okay, so it's the Parkland formula that's gonna be used. And you see I have it listed out there for you. So we figure out what their body weight is. We put in kilograms. And then we determine based on that rule of nines, what is the total body surface area, percentage burn. We multiply all that by 4 milliliters. And that tells us how much fluid that we've got to get in this plant within the first 24 hours. Half needs to be infused in the first 8 hours. Then the other half would be infused over the next 16 hours.
In the old book, it's 4 milliliters, and the new it's 2.
It's 4 milliliters.
It's 2 for 8 hours and then 4 for 24 hours.
So we're just gonna calculate it all together. Just use this formula right here. Yeah, I don't know why you would confuse it that way. And I know I was looking for it in the ATI book, but I know that ATI also goes by the Parkland formula with the 4 milliliters as well. So let's go with the 4.
So we're just calculating 24 hours.
Yes.
And then if we needed to do the half of it, we would add that number.
Correct. So you would get the full number, and then when you divide it by 2, you know that half of it has to be in within the first 8 hours, and then the other half would be in the remaining 16 hours. So the other thing too, subtracting the fluid infused pre-hospital. So if the EMS did get there, they got on site, and they've already gotten 200 milliliters of fluid before they arrived in the emergency room, we would subtract that from what we would need to get in total, okay? So we subtract that from the first 8 hours total, because they've already gotten 200 milliliters out of that first 8 hours. Does that make sense? So you do the 4 milliliters times the kilogram, body weight in kilograms times, you don't do percentage, you just put the number in there, okay? You just put, if it's 54%, you just multiply it by 54. You get your total number, and that tells you how much needs to be infused over 24 hours. So it's a large amount of fluid that they do need to get initially, that's in the emergent phase. We know that this is the phase where all of that fluid is, the hypovolemic state is a big issue in this stage. So any questions about the formula there? Okay. So some of the diagnostic studies, some of the laboratory studies that may be done, CBCs, electrolytes, and like I mentioned, because of all the breakdown of cells, you can have hyperkalemia, and with all the dilution and everything, you can have hyponatremia. So we know we got issues going on with the electrolytes in the body. Checking their ABGs, we know that's gonna be important in those clients that have potential inhalation injuries or confirmed inhalation injuries. Checking their blood glucose, we talked about the metabolic state of the body and the stress that it's under. Liver studies, urinalysis, because we're gonna be looking to see if those kidneys have some damage to them. Chest x-rays, the creatinine level and myoglobin level to be done with the deep burns because of that could tell us how involved the breakdown of the muscle is, how deep it is. So we're gonna be giving them significant amounts of fluid. So when we're monitoring how well our fluid replacement is going, what's our best indicator of how well they're getting?
Blood pressure and
Their
urine?
output, right, their urine output. We wanna be sure that we are monitoring for increased urine output, because if we're giving them, you know, maybe it's 2,600 milliliters, for example, over 24 hours, and we're not even getting 30 milliliters an hour, then they're probably gonna end up pulmonary edema, and then we're gonna compound the issues that they're already having. So we wanna be sure that we are monitoring their urine output very closely. That's the best indication to us that their kidneys are working well and they are getting adequately hydrated. Hypothermia, especially, I mean, we know that our skin is very important to helping us with regulating our temperature a bit. We sweat when we're too hot, we shiver when we're too cold, and so if we've eliminated those mechanisms in the body because we've got full thickness burns, hypothermia can be a big issue. We know that wound care is gonna be very important. It's gonna probably be delayed in the emergent phase, it's gonna be delayed some because they are going to be, because they're gonna be needing to be sure that we get them stabilized at this point. They are probably gonna need some pain management, so it does mention that the use of IV morphine is commonly seen. And then there is a big table of medications, and it talks about the analgesics that may be used, if sedation is necessary, anticoagulants, nutritional support, and then also, GI support. And it does mention decreasing the stomach acid because of the risk of ulcer under the, GI support. And so really that's just in general. I mean, we mentioned that they're gonna need pain medication. You don't need to go memorize every single one of those medications. If you look at the list, most of them are gonna be familiar to you anyway. You know that Zantac or ranitidine is given for, Zantac is given to reduce the risk of ulcers. Nexium, Protonix, you know what these medications are gonna be. You know what anticoagulants are. That information is familiar to you. Another thing that may also be used is albumin. So albumin may need to be infused, and that's gonna help with keeping the fluid in the vascular space. So when our albumin levels are really low, that's where we have a big issue with the increased vascular, increased capillary permeability and the situations where the body's under the stress causing that. Albumin can help with keeping the fluid where it's supposed to be. and increase the vascular volume. So that could help in increasing their blood pressure, increasing their cardiac output, increasing their kidney function. So albumin can be helpful in a situation where we need, that would be considered a volume expander, albumin would be.
Can you, go over the stomach again? So like, they have like a lot of acid buildup and they're at risk for the ulcers?
Yes,
Okay.
so that's something that we need to be monitoring closely for, and be sure they're on these prophylactic medications to prevent those from occurring. Yes. The next phase is going to be the intermediate phase. And this is where we're gonna move to more of caring for the wound and all that may involve. So cleaning it, do you think it's gonna be a sterile procedure to clean the wound? We wanna keep it as clean as possible, but it's gonna be impossible for it to be sterile because of everything that, the layers, the multiple layers of skin and what it has been exposed to. But we wanna be sure that we keep it as clean as possible. There are some topical medications on page 1169 that are mentioned as well, not on 1169. Topical medications are on 1172. Silvadene, that comes to mind immediately, right? When you think about burn, you think about Silvadene. If they are allergic to sulfa, they can't have Silvadene. That would be a contraindication in that situation. Mild soap or chlorhexidine and water can help with debridement of the burn wound. They are gonna try to probably encourage early excision and grafting because we know that, we wanna try to get, well, number one, decrease the length of the hospital stay. The longer they're there, the greater risk of infection and everything that comes along with that. So if we can do early debridement and wound healing and grafting if necessary to try and get them to help provide better outcomes for them. And we already mentioned about pain management. That's gonna be carried through. Just because they got out of the emergent phase doesn't mean that the pain is gonna go away. You know, there's definitely gonna be a lot of pain associated with the wound care, and you wanna be sure that they get appropriate medications prior to that. And then prevention of infection, that's gonna be very important because we know that they are gonna be at a very high risk for infection. So trying to get them the appropriate nutrition and, keeping things clean, doing our best to not introduce any type of infection. The rehabilitative phase really is gonna kind of begin with, you know, even when a client gets admitted for anything, we're already gonna be working towards discharge. So that rehabilitative phase, and as soon as we kind of get things stabilized, we're gonna need to be working on keeping that range of motion. Contractures are a major issue with that, especially with the skin, the way it's affected, and then as it starts healing back, if they're, depending upon where it is in the extremities, it could contribute to contractures. So doing the range of motion, passive range of motion, then when they can start doing active range of motion, get those things in place as soon as it can be done. The rehabilitative phase can last for a very, long period of time, extend well beyond discharge because of, depending upon how much rehabilitation is necessary. But we wanna be sure we do what we can to prevent those contractures that could limit mobility, that then could cause, more functional issues as they're trying to work through that rehabilitative phase. So the, tetanus shot's gonna be important for these clients if they don't have a current one. As far as some of our nursing considerations go, the monitoring for hyperkalemia, because of the cellular destruction. I did mention it is Curling's, like curled hair. Curling's ulcer is the very specific ulcer that is labeled for, that these burn patients are at risk for. So being sure that we're administering appropriate antacids to prevent this potential complication. Because what happens when that plasma volume is decreased, it can lead to ischemia to the gut, and that's what causes it to slow down and put them at risk for a possible paralytic ileus. And then as the ischemia occurs, we know that when blood flow's not there, necrosis can occur. So then that's where we could have sloughing of that gastric mucosa that could put them at great risk for having the Curling's ulcer. The NG tube could be put in place to help prevent the paralytic ileus, because as a result of that ischemia, the bowel activity can be decreased. We want to be sure, we mentioned it several times about their nutrition and replacing their calories, monitoring for contractures and infection, monitoring their cardiac status. We know that as far as pain management goes, IV medications are going to work much quicker. Checking their circulation frequently, pulse, capillary refill time, skin color, skin temperature. We want to be sure they have a Foley in place, because we already mentioned it's going to be essential for us to monitor their urinary output, to be aware if we are adequately hydrating them or if they're going into fluid volume overload. If you start seeing the urine turn red or brown, that needs to be reported, because that could indicate that there's some damage to the kidneys that needs to be addressed. Also, we talked about having an NG tube in place. We want to monitor that NG tube output if we don't have any. And it does go into a lot of details about skin grafting and everything, but we're not gonna. You can see pictures, and you can see, sometimes they may take it from the patient, you know, so maybe it's an upper body, they may take a piece of skin off the leg. So then when you have skin taken from the leg that is then put in another area of the body, now you got two different wound sites to worry about. Sometimes they may use pig skin as a potential grafting tissue, so there are different ways, but you can kind of see that, but we're not going to go into great detail about that. We know that if they, depending upon the severity of the burn, that may be necessary. So any questions about anything? And then this just lists some of the other serious things. Those are mentioned there at the very end of your chapter, just other conditions not related to a physical burn that could be caused by, like Stevens-Johnson syndrome could be caused by a severe allergic reaction to certain medications. So, but it is like the skin's burned because it like blisters and sloughs off. And so those are some other serious skin conditions that could potentially be treated at a burn center as well. So any questions? Okay, so we're gonna do a little activity with the